Hello to all. I'd like to welcome again more than 100 participants to today's exciting webinar. First of all, I'd like to thank the sponsors without whom all this would not be possible. Foremost, our main sponsor, Pharma, but also Implantcast, Novartis, as well as Bayer. And as a further announcement, all the webinars in the past and this one will be very soon available freely on the website www.sarcoma.academy. Now it's my great pleasure to introduce today's speaker, Professor Javier Martin-Broto. He is an oncologist at the University of Madrid, where he moved to from Sevilla earlier this year. He's an MD with a PhD in molecular biology. He has run more than 60 clinical trials, and therefore he is perfectly suited for today's topic. He is the founder of Highrisk, the Spanish sarcoma group, and also the leader of Cellnet consortium through a Horizon 2020 grant, which involves countries from Latin America and Europe. Javier today is talking about areas of improvement in sarcoma care. We are looking forward, and Javier, it's all yours.
Thank you very much, Bruno. It's my pleasure to participate in this specific webinar. So my topic, as Bruno said, is areas of improvement in sarcoma. And I will especially focus on improvements related to systemic treatments. This is my disclosure. And this is the agenda I will go through in this talk. First of all, I will start by localized disease and towards better selection, and then upfront first line in advanced disease. We will make some thoughts about the coffee for all, doxo for all patients. In second lines, is there room for different aims? I mean, we can have options of substantial shrinkage even in second lines. And then we will go to new treatments and what should I know about novelties. And finally, at a glance, some headlines in Ewing, osteosarcoma, and GIST very quickly. Okay. So in localized disease, we have learned in the last 2 decades that it is crucial a good patient selection and an adequate scheme of chemotherapy. Regarding the patient selection, only those patients varying tumors larger than 5 centimeters, grade 3 and deep located were selected within extremities and trunk wall in several consecutive trials testing perioperative chemotherapy and within the adequate also histology selection. The first Italian sarcoma group comparing 5 cycles of epirubicin plus ifosfamide versus no perioperative chemotherapy had the highest dose intensity of the 2 most active drugs in soft tissue sarcoma, epirubicin plus ifosfamide. And the second trial conducted by Italian sarcoma group with Hayes, with the Spanish sarcoma group cooperation, compared 5 versus 3 cycles of epirubicin plus ifosfamide scheme in the same localized high-risk population, and no differences were detected between the 2 arms. But interestingly, the curve from the treatment arms of this first study were run superimposable than the curves from the second study. And here the message is the same high-risk population treated with the same full dose of epirubicin plus ifosfamide obtained the same results, which is, I think, an additional conclusion, a robust conclusion from these randomized studies, the consistency of the findings. So the next study explored the histotype-driven experimental arm in the 5 most frequent subtypes versus 3 cycles of the epirubicin ifosfamide scheme. In the third interim analysis, the Independent Data Monitoring Committee recommended to stop the trial due to significant differences favoring the control arm, epirubicin plus ifosfamide. With a longer follow-up, we can see here in the bottom line, with almost median 5 years of follow-up, these differences still were significant in the overall survival, but not in the disease-free survival. In this study, the patient selection was the same, high risk, and again, the control arm curve run in the same way than the previous study, with an overall survival rate at 5 years of 65%. Currently, Mila and colleagues developed a nomogram to establish a risk estimation for disease-free survival and overall survival after analysis of prognostic factors with impact as a continuous variables, as example is the size. This nomogram has been validated by external series, and it is the most reliable tool for risk estimation at our outpatient care at our office. And a good example of the relevance of the selection of good selection in patients for clinical trials is this ERTC study, which was negative, comparing 5 cycles of doxorubicin plus ifosfamide versus control without any perioperative chemotherapy in localized soft tissue sarcoma. The selection here was more flexible, and patients were included in different sites, even retroperitoneal or visceral sarcomas, and also grade 2 and maybe some grade 1 sarcoma also were included. When we applied the nomogram in this negative study, we can see in the red curves that the highest risk population benefited from chemotherapy, and in discontinuation line with red color represent those patients with highest risk receiving chemotherapy, and this difference was significantly different, favoring the chemo administration. Again, we have learned after this circulator, after this nomogram, a better selection in the recent times is crucial for obtaining positive results in the setting of perioperative chemotherapy in high-risk localized disease. And actually, we are using the cutoff of 40% of the risk for death for sarcoma, applying these nomograms as the cutoff for which the patients could receive the chemotherapy, at least 3 cycles of full dose of epirubicin plus ifosfamide. So then a better risk selection of lymph and trunk wall high-risk sarcomas has been an area of improvement in soft tissue sarcoma. Indeed, in the control arm, the expression of MRP1 was validated as resistant mechanism, and this is currently under review, under publication. This is the algorithm we can apply in localized soft tissue sarcoma in limbs and trunk wall. These 2 locations have a similar biology behavior of sarcoma, and is different than other locations as head and neck or maybe retroperitoneum. So moving on to the advanced disease, the question is doxorubicin the best option for all patients? In other words, coffee for all? We have to admit that doxorubicin is becoming a black widow spider, since every partner that joins eventually will die. The latest example was olaratumab. You can imagine how many deceptions in the last 2 decades, with so many patients enrolled in phase 3 trials with negative results. However, the combination is related with a higher probability of response rate, and this property could be convenient when a shrinkage could facilitate surgery rescue or could alleviate symptoms related with tumor burden or tumor volume. And as you can see here, the combination of doxorubicin with ifosfamide and other compounds renders a higher overall response rate compared to doxorubicin alone. This is a very nice phase 3 clinical trials comparing the combination of doxorubicin plus ifosfamide versus doxorubicin alone with the standard doses of with the doxorubicin in monotherapy, 75 milligrams meter square. And in this study, significant differences were detected in terms of PFS, favoring the combination arm than doxorubicin alone. And we have to take into account that, for instance, trabectedin or pazopanib have been approved, demonstrating significant benefit in terms of PFS and no in terms of overall survival. And this additionally, an intriguing question is what would happen if in the leiomyosarcoma, which represented the fourth part of this population, would be treated with doxorubicin dacarbazine, since we know by retrospective analysis that the combination of doxorubicin plus dacarbazine is more active in the leiomyosarcoma context than doxorubicin plus ifosfamide. Nobody knows, but I mean, this was reported as a negative study because no differences in overall survival were seen, but in PFS the differences were significant, and also in terms of overall response rate. So maybe we have to advise for combination chemotherapy in the scenarios where shrinkage is facilitating the potential surgical rescue, or maybe when we need a fast palliation because the symptoms are related with tumor volume or tumor burden. And these are some examples in the upper left side. Synovial sarcoma, very symptomatic young male patients after the first cycle with the combination of epirubicin plus ifosfamide. In the second week, the patient felt better and recovered the breath difficulties. So this is the CAT scan after a second cycle of this combination. And in the upper right side, another case with bulky synovial sarcoma involving the abdominal and paravertebral spaces. No surgical rescue could be performed at the baseline, but after the combination of epirubicin and ifosfamide, surgical rescue can be done. And in the bottom line, also a high-grade nose sarcomas in the axillary region, impossible to perform an adequate R0 or R1 surgical resection in this axillary tumor, but after several cycles of combination, this could be done. So these are examples. There is a niche for which the combination is more convenient in the first line of advanced disease. So, and maybe the most frequent scenario, it does not make sense to prescribe the combination since the patient is not symptomatic or not surgical rescue is foreseen. For these cases, doxorubicin alone is a rational recommendation. And additionally, we must know that in some sarcoma subtypes, chemotherapy is not the best choice, or maybe doxorubicin is not the best choice. It's the case of non-sensitive subtypes to doxorubicin as solitary fibrous tumor, or alveolus of Mars sarcoma, or extraskeletal myxoid chondrosarcoma, for which another options of the therapies could be attempted before chemotherapy or instead of chemotherapy. Or maybe we will demonstrate that less toxic schemas in myxoid liposarcoma, maybe if the the trabectedin versus epirubicin ifosfamide randomized trial demonstrate finally that this the trabectedin is equally effective than the combination of doxorubicin or doxorubicin plus ifosfamide. And some subtypes have a specific targeted therapy, as the case of PICOMA or NTRK bearing mutants or inflammatory myofibroblastic tumor, for instance. Or maybe we have to consider that in some patients, the morbidities does not advise for doxorubicin based scheme in the first line. So a coffee for all is not a good philosophy. Maybe we have to learn that we have to adapt maybe the first line according to the aim and according also the histotype. So moving on to the second lines, what have learned in second lines management? Is there room for different aims in second lines? As you can see from the pivotal trials, phase 3 pivotal trials, trabectedin, pazopanib, and eribulin exhibited less than 10% of overall response rate. So the three approved drugs stemming from randomized phase 3 trials exhibited very little activity in terms of shrinkage. In the case of gemcitabine in combination, maybe this percentage is higher, but this information derives from a randomized phase 2 trials, which is more weak. So then we can offer some scheme with a higher probability of overall response rate, maybe with a high dose ifosfamide in the case of synovial sarcoma is a good option, but beyond synovial sarcoma, high dose ifosfamide maybe is not relevant. But recently we have seen that the combination of trabectedin and radiation therapy at low doses or relatively low doses can be not only be manageable, not only can be integrated in this scheme, but also we have seen a notorious activity in terms of overall response rate. And this can be explained maybe by preclinical findings that trabectedin exhibits very peculiar properties because in an early phase is behaving as a proliferative factor, and also in an early phase we are detecting DNA damage, which ultimately entails G2M arrest, which is the most sensitive phase within the cell cycle for radiation therapy. And many drugs can make an arrest in G2M, but a notorious property of trabectedin is that inducing an entrance in the cell cycle of many cells in the very early phase of treatment. Some examples with this combination, even in the cohort, metastatic cohort, as you can see in the upper left side, this was a synovial sarcoma, very aggressive, with a very short doubling time. And after a couple of cycles with this scheme of combination trabectedin plus radiation therapy, there was a substantial shrinkage, partial response, and this patient kept under control for 1 year or slightly more than 1 year. And these two other examples of UPS and sorry, because I have to, okay. These two other examples, we can see a kind of response, maybe choice response, or I don't know how can define as a black hole in the lungs, but again with notorious activity, and also this overall response rate was translated in a longer, substantial longer PFS, and also in a substantial longer overall survival. And you can see the waterfall plot is incredible in this phase 2 trial published last year. So this allow us to integrate these two different treatments, and in the cases where shrinkage should be pursued, this is a very good option for that. In the case of central radiology review, there was 60% of overall response rate, and according to local investigators, this percentage was 72%, which is very important, talking about RECIST response, no other response. And also we have seen responses across different, very different histological subtypes, which is also important to mention. And this is another example of leiomyosarcoma with progressing after doxorubicin. This patient had metastatic spread and also regional node involvement. And after, this is at different scale, but after doxorubicin, the tumor increased in size from 97 millimeters to 142 millimeters. And after the combination of trabectedin and radiation therapy, a substantial partial response was seen, and finally the tumor was infected, and this is the situation after this, the drainage of the infection, and the patient is under treatment more than 3.5 years later. So this is a very nice approach in the scenarios where where we need substantial shrinkage. These are algorithms because in second lines we don't have any trial conducting or addressing the question of what is the best sequence in second lines. We don't have this information, but just as a rational approach according to several factors, among them the histology can suggest us to use a specific sequence, but again, it's just a convention. So what about the new treatments? What should I know about the novelties? And what about the immunotherapy in the case of sarcoma? Sarcoma is very different than the melanoma, for instance. Melanoma is a paradigmatic immunosensitive tumor, and sarcoma exhibits a very different microenvironment context compared to tumors where the immunomodulation is working well, as melanoma is an example. Sarcoma has 2 mutations as a median by DNA megabase compared to 14 in the case of melanoma. And also the tumor infiltrating lymphocytes is clearly lower than in the case of melanoma or other tumors where immunomodulation is important. And the same for PD-L1 expression is lower in sarcoma in general compared to other tumors. But some exploration have been made, and we have learned some I think lessons. And for instance, the combination approach maybe is offering higher activity compared to just anti-PD-1. Is the case of this phase 2 randomized phase 2 trial with nivolumab in one arm and nivolumab plus anti-CTLA-4 ipilimumab in another. So the differences in terms of median of PFS were substantial, favoring the combination arm, 4 months versus 1.7, and being the subtype similar in both arms. So another approach is the combination of anti-angiogenic, for instance, axitinib plus anti-PD-1 as pembrolizumab, or sunitinib plus nivolumab, just with the aim of stimulating the microenvironment or convert the microenvironment into an inflamed microenvironment. And again, comparing to sunitinib alone, this is obviously an indirect comparison because these were phase 2 trials or phase 1-2 trials. But in indirect comparison, we observe a longer median of PFS favoring the combination. But obviously, these figures are much lower than other tumors, especially epithelioid tumors or melanoma. But within the universe of sarcoma, some specific subtypes are especially immunosensitive, as is the case of alveolar soft pulse sarcoma. These are two examples of patients enrolled in this nivolumab plus sunitinib trial. In the left side, we can see this important response in this thigh, in this mass in the thigh. And after the resection of this residual tumor, pathological complete response was detected. And in the right, we can see this both CHOI and resist response in some lesions of this metastatic alveolar soft pulse sarcoma as well. So we are collecting a global series of alveolar soft pulse sarcoma treated with anti-PD-1 or anti-PD-L1, and the percentage of overall response rate is almost 50%, around 50%, which is important because, as you know, this specific subtype is not sensitive to chemotherapy. Is in somewhat sensitive to anti-angiogenics, but with anti-PD-1 or anti-PD-L1, I think we are able to change the natural history of this entity, at least in many of them, maybe not in all of them. And also, interestingly, in other ultra-rare sarcomas, as dedifferentiated chondrosarcoma or dedifferentiated chordoma, or maybe rhabdoid tumors, SMARCA4 positive mutants, are also sensitive to immunomodulation, or angiosarcoma is another example. So, but I know in terms of immunomodulation with anti-PD-1, sarcoma maybe is in the last frontier, but in the talking about the cellular therapy, sarcoma maybe is a pioneer. And it's interesting because in translocation-related sarcoma, there are neoantigens that can be targeted using this technique of cellular therapy, mainly through the TCR T-cell therapy. The two most tested so far neoantigens are NY-ESO1 and MAGE-A4, and there are many others. And this technique is also pioneer with respect to CAR T cells. CAR T cells also is very attractive in soft tissue sarcoma, but still the development is in an early phase, in an early clinical trials. So interestingly, with TCR T cell against NY-ESO1 or MAGE-A4, we can see responses even in bulky tumors. It's true that it's most adequate for immunomodulation, maybe with a lower tumor burden, but this could be seen as well. And the first studies were important because they established that the lymphodepletion scheme administration, which is done before the reinfusion of the manufactured lymphocytes, is important in order to maintain a durable response. So the relation is that the highest deep lymphodepletion, the longest the duration of the response, or the longer the duration of response. So this was important in these early trials with TCR T-cell against NY-ESO-1 or MAGE-4. And as you can see in the waterfall plot, there is a substantial activity in terms of overall response rate. And maybe it's too early to know about the duration of the responses, because as you know, we need from immunotherapy that responses could be more durable than other therapeutic approach. So we are still in the embryonic development phase with this technique. Actually, the first European patients with sarcoma, and indeed with any solid tumor with TCR T-cell was treated 1 year ago in Europe. So tazemetostat is important in epithelioid sarcoma, and this entity has two different subtypes, the distal and proximal. But in general, the most important figure of activity with tazemetostat is the duration of response, which is more than 6 months. And the median of PFS is almost 6 months, which are very important figures for this entity, even when the overall response rate was 15% for this targeted therapy. And it's interesting because it's the first targeted therapy in this entity, which was tested. This is the progression-free survival Kaplan-Meier curve. And also anti-CDK4 inhibitors are becoming better, maybe in the inhibition of this amplicon, especially important in the differentiated liposarcoma. And here the numbers of 76% of PFS rate at 3 months is also important, and but yet is under research. And Selinexor is also an interesting drug. Is an inhibitor of exportin 1, which is exporting proteins. Is a cargo protein between nucleus and cytoplasm, and the inhibition retains some proteins encoded by tumor suppressor genes in the nucleus. So this is the SEAL trial, a randomized phase 3 trial in the differentiated liposarcoma, demonstrating a significant improvement in terms of PFS, but a clinically non-meaningful difference, because there were a few weeks, the difference between Selinexor and placebo in this trial. But interestingly, the identification of some biomarkers of resistance will allow a better selection for this compound. And this is interesting because applying this biomarker, the difference becomes clearly greater, and maybe for regulators is important these correlative studies. As you know, we need other mTOR inhibitors in the scenario of PEComas. NAPS sirolimus exhibited a very nice activity in terms of overall response rate and also disease control. Also interesting is the CSF1 inhibition in the context of tenosynovial giant cell tumors. And this is the waterfall plot of pexidartinib. This drug was approved by FDA, but not yet, at least for EMA. And but new CSF inhibitors are under trial now. And also, if we cannot reach any CSF inhibitor by clinical trial, we can advise for imatinib that could work. It's true that it's a weaker compound, no specific compound and but maybe in some instances is working well. Sorafenib is a very nice drug in the context of desmoid tumors. As you know, desmoid tumors, the first option is wait and see for most of situations, but in some cases, we need to advise for systemic treatment. And the sorafenib demonstrated versus placebo a very good activity. I have tested in almost 30 patients the sorafenib in desmoid tumors, in a progressive difficult tumors with a very good experience. And so this is a very, very nice drug. A MEK inhibitor, selumetinib, is also very important in neurofibromas, in plexiform neurofibromas, in the context of neurofibromatosis one, and is also a drug to take into account in this context. Obviously, the very infrequent NTRK mutant in the context of sarcomas have a very specific target therapy with larotrectinib or entrectinib. So these are very, very nice compounds, but again, maybe the frequency of NTRK positive tumors in the context of sarcoma is one between 200 patients. I don't know, but it's very low. And there is a plethora of other rare sarcomas where some targeted therapy, and we should to know that. This is algorithms, maybe is teaching for some of you. And finally, at a glance at headlines, in Ewing sarcoma, we know that in high risk, high dose of chemotherapy with autologous bone marrow transplantation is a standard procedure, and high risk localized is defined as those tumors with larger or with higher than 200 millimeters volume, or with those cases with more than 10% of viable cells after induction. So in the adjuvant setting, after a cycle of chemotherapy, Bummel administration is standard. So it's important, and this has been a difficult conclusion because it was necessary 2 different randomized trials and 15 years to reach this conclusion. And we have the differences here in overall survival applying this high dose therapy in this high risk localized disease. In metastatic setting was not demonstrated. But also it's important the timing and the delays between chemotherapy and surgery, or between surgery and chemotherapy and the starting of adjuvant therapy. It matters, and maybe impact in the event-free survival and in overall survival. This is an information derived from this ASCO 2021, demonstrating the impact of this delay in this timing. So it's important to take into account not only the high dose of Bummel, but the timing is very important. The synchronizing between surgeries and chemotherapy. And also important in Ewing sarcoma is that for first time the transcript, protein transcript of EWSR1 FLI1 is targeted. It's true that the outcome so far is poor, is not very enthusiastic, but important is that this frontier was very difficult to overcome. So it's important to know this. In GIST, we have 2 new drugs, and it's impressive because these drugs have been built according to design, a specific design. And ripretinib is an example. This drug is has been approved in fourth line in GIST, in advanced GIST, rendering biggest difference than in third line with regorafenib versus placebo, which is very important. And in general, this compound is clearly better tolerated than regorafenib or sunitinib, which is very important for this type of patients. So it's important. And any delay in administration of this fourth line is important, because, as you know, almost a vertical line in the placebo, this percentage of patients dropping in a fast way were unable to make the crossover. So it's important to coordinate the third and fourth line quickly. And also avapritinib in those patients bearing this resistance mutant D842V. So the waterfall plot speaks by itself, and is already proven by FDA. I'm not sure by Europe, but is in any case is we can ask for that as a expanded use. It's very important in this context. This is the only drug we use useful. Maybe crenolanib as well, but crenolanib maybe is no longer under clinical trial, so I don't know. And maybe the Tyson kinase inhibitors in progressing osteosarcoma are important drugs. Regorafenib is an example. Lenvatinib is another example. So in this very bad prognosis subset of patients progressing and with unresectable lesions, we can offer these TKI inhibitors in order to give some disease control, which is significantly better than placebo. So the conclusions are the treatment aim is relevant in the first line, and coffee for all is not a good idea for the advanced upfront therapy. We have learned to make a better selection of patients and a full dose with a higher dose intensity in localized high-risk population, soft tissue sarcoma in limbs and trunk wall. So this has been, I think, an advance in the recent times. And currently also we have options of tumor shrinkage in second and further lines with this property from trabectedin and radiation therapy. And some new drugs are landing in the sarcoma field in the last 2 years, and we have here some examples. And this is all. Thank you very much for your attention, and thank you for your invitation. And I'd be very delighted to answer some questions. Thank you very much.
Javier, thank you very much. You really have to be commended for this thorough and exciting overview. I suggest that everyone should ask the questions. Until now, there's none coming in. And I see that Axel is back as well. You are busy with the French Sarcoma Group meeting right now. And thank you very much that you, during your General Assembly, you take the time. And maybe before I start, I would like to hand over to you.
Thank you, Bruno. Thank you, Javier Martin. It was nice talk, nice overview of all efforts we made in the field of soft tissue sarcoma. Unfortunately, the major advances was seen in the rarer sarcoma, not the most frequent one. So, but step by step, we'll move forward. I'm very impressed by the results of the combination of radiation therapy and trabectedin in both local advanced plus metastatic patient. Just a question, it's every kind of histotype, or you've seen more tumor shrinkage in L sarcoma? I give you this question because this morning we tried to build a new French randomized protocol in non-fit patient for doxorubicin in neoadjuvant situation. So it means in elderly patient. So one of the discussion today was to build a protocol comparing, for example, radiation therapy in neoadjuvant situation, or radiation therapy alone versus combination of radiation therapy plus trabectedin in order to validate your data. And because trabectedin can be given in non-fit patient for doxorubicin. So my question is, can we include every kind of patient or only L-sarcoma, lipoleio?
Yeah, this is a good question. We have seen responses across several subtypes, synovial sarcoma, undifferentiated pleomorphic sarcoma, even in more infrequent subtypes. In this specific trial, there was no restriction of histotype, or in other words, there was flexible inclusion of several histotypes beyond L-sarcomas, and I think there were 11 or 12, 11, I think, counting the phase 1 and 2 parts, different subtypes. So we have seen activity in all of them, and this has been an argument for the Synergies trial. Synergies trial is focusing on the symptomatic relief with this approach in second or further lines in soft tissue sarcoma, but in other scenarios where even trabectedin is not approved. So we want to explore this property of this synergistic action beyond soft tissue. Soft tissue will be obviously one cohort, but another will be bone tumors, especially osteosarcoma and chondrosarcoma, and another small round cell tumors as Ewing, desmoplastic, and also rhabdomyosarcoma. We have seen spectacular responses in fourth line in rhabdomyosarcoma, in embryonal rhabdomyo. So I think this property, this synergy, is seen beyond L-sarcomas. We are very convinced of that.
There was a question from the audience. Do you have a suggestion of duration of second-line treatment, for example, PKI, in patients with stable disease?
Yeah, it's hard to say, but usually our French colleagues have conducted several trials addressing the question of duration of several in several contexts. But you know, the usual situation, for instance, for pazopanib, which is approved, as you know, in second line, is to advise to use pazopanib up to progression or up to intolerance. So no holidays is not convenient if the drug is able to keep the tumor under control. So this is the strategy we are using, and this is the same for trabectedin, and even with gemcitabine dacarbazine, for instance. Gemcitabine dacarbazine, we have patients treated for more than 2 years. So when the cumulative toxicity is not a problem, then the approach is to use in a non-stop way. It's true that sometimes you have to delay the cycles. For instance, trabectedin, instead of every 3 weeks, we can advise for every 4 weeks, or maybe with lowering the dose in some way. But no holidays is most convenient. Is more convenient to do that.
Yeah, no, there's just another question coming in. For first-line therapy in potentially resectable tumors, do you use a histotype-tailored strategy, as the neoadjuvant trial was negative? Concrete but potentially resectable leiomyosarcoma, what would be your preferred regimen?
Yes, we are using this histotype approach because in the case of leiomyo, we prefer to use the combination of doxorubicin plus dacarbazine instead of epirubicin plus ifosfamide. I know we don't have a prospective randomized trial to do that, but sometimes in rare tumors as sarcomas, we will not have randomized trials for every scenario. There are too many different sarcomas, and this is very hard to pretend to have to achieve all the evidence level for every decision. But yes, we perform this approach for leiomyo. We prefer this combination approach in those cases where maybe surgical rescue is an option, or maybe fast relief is needed.
We have had this morning also a long discussion regarding this question: what is the best regimen in neoadjuvant situation? I mean, one target agent based on foundation medicine, based on the problem when we see a patient with a localized disease, it's a potential curable disease. So it's complex to spend a lot of time to try to find the right target with this new biological approach. We spend not only money but time, and during this period the tumor grows. So for localized disease, for patients where there is a discussion of neoadjuvant situation, whatever, radiation therapy or chemotherapy, not for operable patient where surgery has to be done upfront. But for the other patients, there is some psychological stress for the patient. Try to give me the right chemotherapy regimen based on my tumor biology. But to have the answer, it's a complex way. So and during these times, tumor grows, and maybe we can lose the operability only based on biological approach. So we have to remain in this situation relatively simple. Today, doxo-ifo for aggressive grade 3 remains the standard. For leio, it's doxo-dacarbazine. I totally agree. For the other, for alveolar soft tissue sarcoma, where it's chemo-resistant, it's better to operate upfront because there is no argument to give pazopanib or regorafenib in neoadjuvant situation. So the only trial where trabectedin could be used in neoadjuvant situation is myxoid liposarcoma. There is one phase 2. But for all, fortunately or unfortunately for the patient, the majority of patients were seen with a localized disease in the, for example, not in the retroperitoneal part, but in lung, in lower and upper arm and trunk. The vast majority of sarcoma are lipo, leio, sino, and angio, and UPS. The other are rarity. So we have to find 5 different protocols for this find more frequent histotypes.
It's true. I have understood the question as the first line in advanced disease. I don't know if was launched as localized disease. I don't know, but I understood the question as advanced disease and potentially resectable case. But I agree with Axel. Maybe, for instance, in some rare tumors, as solitary fibrous tumor, which the anti-angiogenic is more important than chemotherapy in terms of in terms of disease control, in terms of PFS, for instance, and even in terms of overall survival, but no in terms of shrinkage, because the activity should be measured by CHOI response, but no by RECIST. But in this case, radiation therapy is very, very active. In some cases where solitary fibrous tumor is locally advanced and resectable, or in the limit of resection, maybe radiation therapy in a neoadjuvant setting could be convenient for these patients.
Another question is, in a very chemo-resistant sarcoma, such as desmoplastic small round cell tumor, what is your first-line approach, usually very chemo-resistant? We have a protocol using I4-Adria, dactomycin, and vincristine.
Yeah, in this desmoplastic small round cell tumor, we usually prescribe Ewing-like approach. I know it's different the activity, but for the first line, I usually prescribe BDC IE alternate as in Ewing sarcoma, and second lines also similar to second lines in Ewing sarcoma. But it's true that trabectedin, for instance, has rendered with some important responses, and we have seen publications with this activity. But it's obviously, if you have a clinical trial for which this specific subtype can be enrolled, is convenient, because it's yeah, we need to know more about this entity, specific entity. So it's hard to say, but my approach is a Ewing approach, and the first line is with the Ewing scheme, the overall response rate maybe is 30% or 40%, but the patient usually notice some clinical benefit, but you know, radiologically is hard. The first approach should be also consider an extended surgery as much as possible. And then the tragedy is with the second or third line, where the patient is very symptomatic, and maybe you can offer nothing or very few relief. But I think in some instances, trabectedin has demonstrated partial responses, and I think is an example of we need more research in this entity. Yeah.
There's another question. What is the rate of conversion, meaning from unresectable to resectable in patients with second and third line?
Yeah, it's very few. Obviously, it's very few, and actually, we thought only if high dose phosphamide was the only regimen that could add that could offer a substantial shrinkage in second or third lines, especially in synovial sarcoma. But this combination of trabe plus low dose radiation therapy, 30 grays in 10 fractions, has surprised us. So we pretended an integration of this palliative approach with radiation therapy, because this integration is not made for pathopany, for instance, or is not made for gemcitabine. But it was surprising for us, this so big activity. So I don't know, this should be validated, this should be explored additionally. And we should mention that these patients enrolled in TRAS cohort A in metastatic setting were not candidates for SBRT, because the tumor burden was clearly beyond SBRT technique. So I think it's important to know that.
There is a group of patients named oligometastatic patient, maybe 5 to 10% of our all patients. Some patients relapse only with 2, 3 nodules, even after first line, second line, third line, some leiomyosarcoma, some synovial sarcoma also. In this situation, we have to be aggressive, really. We can maintain alive for a long time patient with a combination of one chemotherapy line followed by local therapy, whatever the local therapy, radiation, stereotoxic radiation therapy, surgery, radiofrequency ablation, cryotherapy, whatever. But the combination, even repeated over the time, can maintain alive 5% of our patients. So when you have a long interval relapse between the last local treatment and the relapse, we have to be aggressive even in second line, third line, fourth line, but it's not clearly the majority of our patients.
Yeah.
Maybe also in this context, there's another question. In your experience after second line in patients with metastatic soft tissue sarcomas, what impact does quality of life versus response have?
Yeah,
Versus?
response. Yeah, I think is we are exploring this in a prospective trial now, and just just enrolling patients with symptoms, and these symptoms should be related with lesions that will be considered target lesions. So I think this is I think it is in general the sarcoma patients is true that the performance status is in a good score even in the third line or even in fourth line sometimes. It's true, but it's also true that we have many symptomatic patients beyond the first line or so this is somewhat which is important. I think the shrinkage is related with palliation, with symptomatic relief, but it's not necessary always to achieve a shrinkage. Sometimes you can achieve a palliation, a symptomatic relief, even in the stable disease. And the patient can mention that I feel better, and you are not seeing a shrinkage in the CAT scan, for instance. So it's not always the relationship. In other words, you can see symptomatic relief in spite or despite no partial responses, for instance. But in the contrary is also true. If you are able to give shrinkage, partial responses, this patient will be relieved. I think
the problem is to try to maintain this response over the time. So you can, of course, we have to start with a combination of whatever, doxorubicin or docetaxel. There is clearly an amelioration in some patients, but after 5-6 courses, we have to stop this treatment due to the toxicity reason. So in the future, we have to think more in a maintenance therapy of whatever. It's not possible with doxo, it's not possible with EFO. We have to find with this new target immunotherapy approach, TKIs. We try to build protocol worldwide, even with Switzerland Center, try to randomize the maintenance therapy versus nothing. But maintenance not means the same treatment than the first line. Maintenance could be also to change the drugs, but in a context of tumor shrinkage, what remain tumor cells. The complete response is less than 1% when you take in charge of patients. So it's a very rare situation. So when you stop treatment, after PFS of 3 months, tumor regrows. So we have to build some protocol in this situation to maintain dormancy the tumor cells over the time.
Yeah, do you remember, Axel, there was a clinical trial addressing this question with mTOR inhibitor.
It was negative.
It was positive, statistically speaking, but unfortunately
3 weeks. 3 weeks.
Yeah. This was a pity, but this way I think is very interesting, and maybe we needed to better selection for mTOR inhibitor, because I had some patients with a long-lasting disease control in that trial. So unfortunately, we didn't have any predictive biomarker, but but this approach is very attractive.
It is what we made in ongoing trial named Multisarc here in France. So we tried to we made a biologic test in frontline chemotherapy regimen in order to try some targets, altered pathway. But we treat the patient normally with doxo, EFO, and if we find the targets, we try to propose drugs against these targets in maintenance therapy versus nothing, to try to, in each selection of patient exhibiting a pathway, an altered pathway, we try to ask this question.
It's true that there is no actionable genomic findings in all patients. It's true, but it's a very nice approach so far. Yeah.
You know, the algorithms that you presented, they are extremely nice and appealing. Where do you see the greatest challenge to logistically address, let's say, these questions? I mean, how can we organize that? You know, before you, of course, mentioned that we have to collect on a worldwide basis, but what do we have to change to move forward? Where do you see the greatest challenges?
Do you mean for this kind of clinical trials exploring the maintenance phase, for instance? I think we should address this question with some already active molecule, and ideally we should know about some biology and some specific biomarkers that could orient the use of this drug. I think this should be nice, and obviously I think this requires maybe a global approach if we are selecting by specific predictive biomarkers, these maintenance drugs. But I think for me it's extremely attractive in a front line, because this could extend the PFS very long away from now. I think this is a very appealing approach. But I think we need a very good drug, a very good candidate. I don't know if immunotherapy is enough, because the PD-1, PD-L1 pathway in sarcoma is working in a very few subset of patients, and according to Petit-Pré, in those patients exhibiting a TLS, tertiary lymphoid structures. So this could be but this biomarker is only expressed in less than 20% of sarcoma patients, 18%. So maybe it's not enough for conducting this immunotherapy with anti-PD-1 as maintenance. But in any case, we have to thought about that. I think it's important.
Maybe a very last question. We have not talked about the important aspect of systemic treatment, but considering the multidisciplinary disciplines and the treatment of sarcoma patients as a whole, where do you see there the areas of improvement?
Yeah, obviously in radiation therapy, there are many areas of improvement. Different fractionation is tested. Hypofractionation maybe is also most convenient for the patients, because it lasts less time in delivering the same dose, and this is somewhat that could be very interesting. I cannot speak about the surgical advances, but obviously surgery is the cornerstone of localized disease and of oligometastatic disease in sarcoma. And I think the synchronization between teams is important, according to this relevant abstract that Uta Dirksen presented in this ASCO meeting. So the timing is important in these multidisciplinary teams, and I think different approaches maybe with different I don't know, cryotherapy in the desmoid tumor, I don't know is working well or not. I don't know, but for surgery advances, you will be more appropriate to answer, Bruno, than myself. But I think, yeah, the multidisciplinary teams is important.
For me, it remains the initial taking charge of localized disease. 90% of our patients, so we try to. Since 30 years, I made the job. Today, I see always unplanned surgery, R2 resection, R1 fragmented resection. We have to avoid that. So we have to make a progress to try to take in charge initially correctly a localized disease with a biopsy. We have to improve our radiologist, the care doctor, whatever, to think it is possible it is a sarcoma. Then we make a lot of progress. All this drug after is try to salvage the non-optimal initial taking charge of this patient.
So I think that's a very nice word of concluding our webinar. I'm not going now further to the artificial intelligence and its future impact, but I think it's really, we need to get down to earth, and we can, just doing this, we can improve lots in our sarcoma care. Again, I cannot thank you enough. Thank you for your nice overview. It's always a lot of work, and we only can appreciate that you share that with us. It's also very nice to have the discussion with you together, and to the audience submitting these questions. I think this makes this webinar even greater. Again, having said that, we have our sponsors, Pharma, Novartis, Bayer, and Implancas, who support us to do this, and we are very grateful about that. And with this, I only thank you for your time, and see you in our next webinar on September 2nd with Axel again.